Good evening, everyone. I thank Dr. Rahul for giving me this opportunity. So we go to the topic, Crimson Skies Macular Hemorrhages. So macular hemorrhages occur due to alterations in the retinal or choroidal circulation. So why is characterization important? One, it gives a clue to the clinical condition, and two, it is a diagnostic sign for an underlying systemic vascular disorder. So based on the on which in which layer the hemorrhage happens, it can be divided into subhyaloid or preretinal hemorrhage, sub-ILM bleed, an RNFL bleed, intraretinal bleed, subretinal and sub-RPE bleed, and very rarely they can be mixed bleeds which happen in multiple layers. Now first coming to the subhyaloid hemorrhage. Subhyaloid hemorrhage has got a characteristic boat or a D-shaped shape. It happens between the posterior limit of the eye of the vitreous and the internal limiting membrane of the retina. And because of gravity, the red blood cells gravitate down and forms a horizontal blood level at the top. So the blood can also shift with the position of the head. And on OCT, you can see a high reflective membrane indicating the posterior hyaloid, the red blood cells posterior to it, and you can see the details of the retina to a certain extent. A sub-ILM bleed occurs between the taut ILM and the retinal nerve fiber layer. Because it's trapped under the taut ILM, it does not move with the position of the head and it is dome-shaped. So this is a sub-ILM bleed. There are a few signs that you can look for. One is called as a double ring sign when there is both a sub-ILM as well as a subhyaloid hemorrhage. Two, an exclamation mark sign, which is a glistening light reflex on the ILM. And three, an arcus retinalis, which is a white ring at the edge of the ILM bleed. So this is an OCT of an ILM bleed. You can see the taut ILM which is separated, and the blood is so dense it causes shadowing posteriorly. So when you differentiate between a subhyaloid and sub-ILM, a subhyaloid is boat-shaped, sub-ILM is usually dome-shaped. A subhyaloid shifts with the position of the head, whereas sub-ILM does not shift. Subhyaloid resolves faster because it's amenable to treatment better. And two, the sub-ILM does not resolve so fast. And for a subhyaloid hemorrhage, the underlying retinal layers are typically visible on OCT, whereas in a sub-ILM bleed, the underlying retinal layers are often obscured. Now coming to the retinal hemorrhages, the first one will be the superficial hemorrhage or the RNFL hemorrhage, which is called as the flame-shaped hemorrhage. It is flame-shaped because it follows the parallel construction of the ganglion cells and the distribution of the RNFL. It lasts approximately 6 weeks and typically occurs due to pathology of the superficial retinal capillary plexus. In contrast, we have a deeper hemorrhage which is called as intraretinal hemorrhage or the dot and blot hemorrhage. It happens in the inner nuclear and the outer plexiform layers of the retina. It is dark red, sharply outlined and dot or blot shaped. It tends to happen in the deeper layers, more compact layers of the retina, and hence it cannot spread out like a flame-shaped hemorrhage. It happens due to disorders of the prevenular deep capillary plexus. So when you consider the OCT of a flame-shaped hemorrhage will show a very high reflective spot in the superficial retinal layers with posterior shadowing, whereas deeper hemorrhages are smaller and they appear as hyper-reflective lesions with posterior shadowing. Now coming to the deep layer hemorrhages, the first one is a subretinal hemorrhage. A subretinal hemorrhage happens between the photoreceptor layer and the retinal pigment epithelium, and because it is not constricted by the RPE, it spreads out and hence its borders are usually indistinct. The hemorrhages are deep red in color and you can see the retinal vessels going over it. In contrast, a sub-RPE hemorrhage happens between the RPE and the Brooks membrane. It appears dark and it has got a well-defined sharp border because RPE limits the spread of the blood. So here you can see there is a deep layer hemorrhage, and on OCT you can see that the blood is both in the subretinal as well as in the sub-RPE component. It has got a sub-RPE and sub-retinal component, and because there is blood in the sub-RPE component, there is shadowing posteriorly. So how will you differentiate between these? Subretinal blood is bright red, whereas sub-RPE blood is usually darker and sometimes even black in color. Subretinal blood is more harmful to the photoreceptors, whereas sub-RPE blood is less toxic because of the limiting effect of the RPE. And subretinal blood is more amenable to displacement, whereas sub-RPE blood is poorly amenable to displacement. Now, coming to approach to macular hemorrhages, in here you have to consider the type of the hemorrhage, the bilaterality, the age, and what treatment you're going to give. Depending upon the type of hemorrhage, subialod and a subialum bleed usually have a similar pathology. They're most commonly caused due to a valsalva retinopathy, PDR, Terson syndrome, trauma, and blood dyscrasias. Flame-shaped and dot and blot hemorrhages usually have a common pathology, usually due to systemic vascular problems like hypertension, diabetes, occlusive diseases, even blood dyscrasias. And subretinal and subarachnoid bleed can again have a similar pathology, most commonly due to neovascular AMD, PCV, RAP, or trauma. Mixed bleeds, when bleeds happen in multiple layers of the retina, it is called as a mixed bleed. So, for example, you can have both flame-shaped as well as dot and blot hemorrhages in vascular disorders like diabetes, hypertension. You can have all layers bleed, that is subretinal, intraretinal, and preretinal bleed, specifically in conditions like RAM and trauma, as well as in valsalva retinopathy. You can have both subhyalod and subialum bleed in valsalva, Terson's, and trauma. Now, trauma in any age can cause hemorrhages. Trauma can cause retinal hemorrhages in any age group. But if you see bilateral hemorrhage in very small children, you have to think about a child abuse. If you see hemorrhages in young adults, you have to more think in terms of valsalva, hematological conditions, blood dyscrasias, and autoimmune conditions. And if you see bilateral hemorrhages in a little middle-aged or elderly patients, you have to think about systemic vascular disorders like hypertension or diabetes. Now, coming to treatment, when you go, before to think about treatment, you have to go through a thorough history, that is regarding medication use, history of trauma, or performing a valsalva maneuver, history of using anticoagulants. Then you can even do a systemic examination, including a peripheral smear and coagulation profile, and do a multimodal imaging, including OCT, fluorescent angiography, and ICG angiography if required, as well as a fundus photography. Now, how will you treat? Now, coming to subhyalod and subialum bleed, if it's a small hemorrhage and it's not vision threatening, you can observe. Whereas if it's a dense bleed, severe vision loss, and acute onset with a clear media, you can consider ND-YAG laser hyalodotomy. If it's a dense bleed, you have to consider pars plana vitrectomy. So in a YAG laser, you make a small nick in the posterior hyalod so that the blood drains into the vitreous. However, you have to warn the patient that even though there can be an initial improvement, if the vitreous hemorrhage spreads, it can again cause a further drop in vision and he will require vitrectomy. So this is a patient who presented with a young patient presented with a non-resolving vitreous hemorrhage. After doing a pars plana vitrectomy, you find that the vitrectomy is being done. You find that the ILM is very taut and there is blood debris under the ILM. So it was actually a sub-ILM hemorrhage which had broken through to a vitreous hemorrhage. So the ILM is being repealed. So you can see the debris under the ILM. It's actually the RBCs, and that is also being removed. And fluid air exchange is being done. For a frame-shaped and an intraretinal bleed, no direct treatment for the hemorrhage is required. It's actually the treatment of the underlying cause. For a subretinal and a sub-RPE bleed, so small bleeds, you can treat it with anti-VEGF injections alone with or without focal laser or PDT. But large bleeds require pneumatic displacement because blood is toxic to the retina, with a TPA or followed by anti-VEGF injections. If there is a breakthrough bleed, you will require pars plana vitrectomy with a subretinal TPA. So this is an example of a subretinal bleed which has undergone pneumatic displacement with TPA, tissue plasminogen activated TPA, followed by anti-VEGF injections, and you can see the significant improvement in the OCT. Thank you.